Hi, my dear students. I'm Dr. Jeetu. I'm a periodontist. So, the most basic chapter of Perio is gingiva and tooth supporting structures. The references currents are 13th edition. 13th edition is the recent most edition. It's an excellent book. Okay, so gingiva. The tissues of gingiva have classically been subdivided into three portions topographically. There are three topographical portions: marginal or unattached or free gingiva, attached gingiva, and interdental gingiva. As you can see, the marginal or unattached or free gingiva is the border of the gingival sulcus, and since it is bordering the gingival sulcus, it is not attached anywhere, so it is called unattached gingiva or free gingiva. And you can see a free gingival groove or a marginal groove. Below that starts the attached gingiva, or more accurately, apical to that starts the attached gingiva. This is firmly attached to the underlying periosteum. Then in between two teeth you have a portion known as the interdental gingiva. This interdental gingiva has marginal gingival portion bordering it and the attached gingival portion in its center. So interdental gingiva is a topographical portion of gingiva which has portions of marginal gingiva as well as attached gingiva in it. See the figure, there is a marginal gingiva, there is an attached gingiva. Then you have a mucogingival junction. This separates the gingiva from the alveolar mucosa. So we know what is free gingival groove. It separates the marginal gingiva and the attached gingiva. Where is this free gingival groove more pronounced? It can be asked. It is on the vestibular aspect of the teeth compared to the palatal or the lingual aspect. And most frequently it occurs in which area? Least frequently it occurs in which area? Most frequently it occurs in the incisor and premolar regions of the mandible. When it is most frequent in the incisor and premolar region of the mandible, it is least frequent in the molar region of the mandible, also premolar region of the maxilla. So most frequent in the incisor and premolar region of the mandible, hence what is left out? Molar region of the mandible. There it is least frequent. Also in the maxillary premolar area it is least frequent. Okay. Then under absolutely normal or ideal conditions, okay, sterile conditions or ideal conditions, depth of the gingival sulcus is about 0. The depth is 0 or a gingival sulcus does not exist. In histological sections, it has reported to be 1.8 millimeters. And there is a range which varies from 0 to 6 millimeters. But clinically, the probing depth, when we probe a gingival sulcus, what is considered normal? 2 to 3 millimeters is considered normal. This is important. Under ideal condition, it is 0. In histological sections, it is 1.8. But when we probe clinically, we get a depth of 2 to 3 millimeters. Coming to mucogingival junction. Mucogingival junction is an important structure. It separates the gingiva and alveolar mucosa. It is clear from the term mucogingival junction. Alveolar mucosa and gingiva's junction. Okay, that also it can be particularly localized on the vestibular aspect. Just like the free gingival groove, it is more pronounced on the vestibular aspect. And we have three techniques to localize the mucogingival junction. It can be localized functionally, anatomically, and histochemically. Functionally, it is assessed by the passive movement of the lips and the cheek. So, how do we assess? The attached gingiva is a structure that is attached to the underlying periosteum and hence it do not move. The alveolar mucosa will be displaced. So, where is the junction of the movable and the immovable tissue? That is the mucogingival junction. That is the functional assessment. Anatomically, how do we found? There is color difference as well as difference in surface characteristics between the attached gingiva and the alveolar mucosa, right? And the third technique is histochemically. Histochemically is by the application of Schiller's iodine solution. This is very important. Schiller's iodine identifies attached gingiva and alveolar mucosa separately. So which structure does this stain and which structure it does not stain? In textbook it is given it stains the keratinized gingiva, which is wrong. The Schiller's iodine stains the glycogen which is stored in the lining mucosa or the alveolar mucosa. So Schiller's iodine is staining the alveolar mucosa and hence it separates the attached gingiva and alveolar mucosa so that we can find the mucogingival junction. Now topographically, the location of mucogingival junction is a stable position. Even with increasing age, the mucogingival junction remains a constant. While being a constant value also, The position of the mucogingival junction, which is obtained by the functional method, is 0.5 millimeters apical to that with the histochemical method. If you get the position of the mucogingival junction with the histochemical method, that position is believed to be more accurate and it is at a coronal position, or the functional method gives us a more apical position of the mucogingival junction. Another important question is width of attached gingiva. It is greatest in the incisor region and it is having a least width in the premolar area, specifically first premolar area. So it is greatest in the incisal region, as we said. In the maxillary incisal region and mandibular incisal region, what is the value? 3.5 to 4.5 millimeters is the width of attached gingiva in maxillary incisor region, and it is 3.3 to 3.9 millimeters in the mandibular incisor area. It is more in the maxilla. When you visualize a oral cavity or you visualize a denture only, you can understand this. Width of attached gingiva will be maximum in the maxillary incisor region, and it is 3.5 to 4.5 millimeters. Mandible, it is 3.3 to 3.9, and the least width is in the first premolar area, as we said, and first premolar area of maxilla it is 1.9 and of mandible it is 1.8. Just like the incisor area, the maxillary area is having a more width when compared to the mandibular area, right? Now coming to the next portion of gingiva, the interdental gingiva. The interdental gingiva is a pyramidal structure in the anterior region and it is cone shaped in the posterior region. So this portion, the cone, is a non-keratinizing epithelium. Therefore, it is a structure that is particularly susceptible to noxious substance or physical trauma, and it is the most frequent site of irritation or pathological breakdown. So cone is a non-keratinizing epithelium. So what happens? This area is very susceptible to trauma or infections. A secondary reason why cone becomes a susceptible area is it is inaccessible to our cleaning, right? Cone areas, it is interposed between two teeth and our interdental aids are the only medium. The regular toothbrushing will not clean this area. So cone is a non-keratinizing area and it is susceptible to noxious substance and physical trauma. One more thing is, because of this feature, cone is often the first area to get affected when you have a periodontal disease. Now, our gingiva has an epithelium and a connective tissue. First, we'll discuss about the epithelium. Three different areas of the epithelium can be defined from morphological and functional point of view. These are oral epithelium, sulcular epithelium and junctional epithelium. Look at the figure. The outer portion is the oral epithelium and the epithelium lining the gingival sulcus is the sulcular epithelium, and junctional epithelium is the junction between tooth enamel and gingiva. So oral epithelium, sulcular epithelium and junctional epithelium. So my dear students, what kind of epithelium our gingiva has? It is a keratinizing stratified squamous epithelium, right? Keratinizing stratified squamous epithelium. It consists of 4 epithelial strata: stratum basale, stratum spinosum, stratum granulosum and stratum corneum. These 4 layers, and what happens in these 4 layers or what are the important features in these layers is very important. You will get questions, okay? Again, from bottom to top: stratum basale, stratum spinosum, stratum granulosum and stratum corneum. The first layer is stratum basale. Look at the figure, okay? See this figure repeatedly. N number of times you can visualize this figure so that it gets fixed in your mind. So you don't have to sit and by heart cells of stratum basale or cuboidal. No need. If you look at the figure, you can see it is a cuboidal cell. So repeatedly when you visualize this, it gets fixed in your mind automatically. The figures are easier to fix in your mind, so it will be there in your mind. Cells are mostly cuboidal, but sometimes it can be cylindrical and they are in contact with the basement membrane. What is basement membrane? Basement membrane separates the epithelium and the connective tissue. Because it is the deepermost layer, it will be in contact with the basement membrane. These basal cells possess the ability to mitosis. So these are the cells which repeatedly divide and they are continuously being renewed. And this layer is also known as stratum germinativum. The germination process or the mitosis happens here. Therefore, stratum germinativum, or it is also known as the progenitor compartment of the epithelium. Another important point is these cuboidal cells are attached to the underlying basal lamina. We already said it is by the means of hemidesmosomes. We know cell to cell attachment is usually by desmosomes, right? So this cell to basement membrane attachment is by hemidesmosomes. What are the key points in stratum base cell? Cuboidal cells, ability to mitosis, and hence known as germinativum or progenitor compartment, and attached to the basement membrane by hemidesmosomes. Coming to spinosum, immediately suprajacent to the base cell layer. Look at the figure. Above the stratum base cell, we have the stratum spinosum. This layer is characterized by spine-like or prickly appearance, and hence the name. So this epithelial layer, when we look at the light microscopic level, we can see bridges between the adjacent cells. There are so many bridges between the adjacent cells, and while we process this tissue to visualize into the microscope, what happens? The cell shrinks a bit. When these cells shrinks, but it still have attachment to the adjacent cell through these bridges, what happens? We can visualize a number of short cytoplasmic processes. Okay, so this spinosum layer has 10 to 20 cells, okay, 10 to 20 cells of large polyhedral cells. Polyhedral, the shape is polyhedral. Base cell was cuboidal, spinosum layer has polyhedral cells, and as we said, it has short cytoplasmic processes resembling spines, and the cytoplasmic process occur at regular intervals, giving the cell a prickly appearance, and hence the name stratum spinosum, right? Coming to an important question, the uppermost cells of the stratum spinosum and the stratum granulosum contain numerous dense granules known as keratinosomes or Odland bodies or lamellate bodies or membrane coating granules. This is a question which has been asked repeatedly. So, which cell layer possesses keratinosomes or Odland bodies or lamellate bodies or membrane coating granules? The uppermost layers of the spinosum and the granulosum layer, both these layers will show these structures. The structure has 4 names: keratinosomes, Odland bodies, lamellate bodies, membrane coating granules. And these are the modification of a cellular structure. It is a modified lysosome, and they contain a large amount of which enzyme? Acid phosphatase enzyme, and it is closely related to the degree of keratinization. When there is more amount of acid phosphatase, it means it is better keratinized, right? So the cell shape is polyhedral. It has spine-like processes. It has keratinosomes in its uppermost layer, and predominantly it is present in the stratum granulosum layer. Don't get confused. Where are keratinosomes or Odland bodies found? In the uppermost layers of the spinosum as well as the granulosum layer, and they are modified lysosomes possessing acid phosphatase enzyme. Coming to stratum granulosum, again look at the figure, look at the basal cell, spinosum cell. Now we are in the granulosum layer. It is flattened now. The flattened cells of the granular layer are notable for the fact that they have keratohyalin granules. They have granules. Hence the name stratum granulosum. So, major feature is keratohyalin granules are present, and one more feature is keratinosomes are present. We already spoke about that in the previous slide. So, if you get a question in which layer keratinosome is present, it is stratum granulosum. And if spinosum is also there in the option, and A and B or both A and C, such an option is there, go for that. If the option has spinosum and granulosum, I think granulosum is a better option, because the full granulosum layer may have keratinosome, but only the uppermost layer of the spinosum has the keratinosome or Odland bodies, right? Coming to the topmost layer, the stratum corneum. Again, look at the figure, visualize the basal layer, spinosum layer, granulosum layer, and finally we are in the corneum layer. The intercellular process of keratinization is completion, and the cells get transformed into a corneocyte. Corneocyte again gets flattened. By the granulosum layer was already flatter when compared to the spinosum layer. This corneum layer becomes compressed, flat, and parallel to the surface of the gingiva. And what is the cell processing? Primarily, it is composed of packed tonofilaments, and they are embedded in a less dense matrix. Okay, here the organelles all become rare and difficult to recognize. Primarily, it is full of tonofilaments. It gets keratinized, gets packed with tonofilaments. The intracellular, synthetic, and respiratory machinery, Golgi bodies, mitochondria, everything gets lost. These machineries are all important for an active cell or a dividing cell. They were very important in the basal layer. Now, because of the differentiation process, it has lost all these, and it gets fully packed with tonofilaments. Now, types of keratinization. A complete keratinization process will lead to the production of orthokeratinized layer.
What is the specialty of an orthokeratinized layer? First thing is it is a complete keratinization process. The features are there is no nuclei in the stratum corneum layer. We already said stratum corneum layer is not having any mitochondria, any Golgi bodies and all that. It lacks nucleus also. And it will have a well-defined stratum granulosum layer, okay, in an orthokeratinized epithelium. In parakeratinized epithelium, it is a partially keratinized epithelium. Orthokeratinized was a complete keratinization. Here, the stratum corneum will retain a pycnotic nuclei. In ortho, there was no nuclei. Here, there is nucleus present, but it is pycnotic. Pycnotic means there is shrinkage of the nucleus. And here, the keratohyalin granules are dispersed. In orthokeratinization, it was well defined. Here it is dispersed and there is no well defined granulosum layer. How do we remember this? Connect all the P's. Parakeratinized, okay, partially keratinized epithelia, pycnotic nucleus. There is P in everything. So parakeratinized is partially keratinized. It retains a pycnotic nuclei. And since it is partially keratinized, you should remember that keratohyalin granules are dispersed and there is no well-defined granulosum layer. Only in completely keratinized layer there is well-defined granulosum. Now non-keratinized epithelium, it neither has granulosum layer nor it has corneum layer. So basically, non-keratinized epithelium has only two layers, stratum basale and stratum suprabasale, and the superficial cells will have a viable nucleus. Clear? Now, we were talking about cells of each layer, right? What are these cells? We'll see. 90% of the cells are keratinocytes, okay? And the remaining 10% of cells are non-keratinocytes or clear cells. That means they do not produce keratin. So, the three major non-keratinocytes or clear cells are melanocyte, Merkel cell and Langerhans cells. First we'll see about melanocyte. There is figure on the right side. Melanocyte is a stellate cell or a star-shaped cell with numerous dendritic processes. And where is the cell found? Where is each of the clear cell found is an important question. Melanocyte is found in the basal and the spinous layer of the gingiva. Okay. From bottom you can see the first two layers, basal layer and spinosum layer. They synthesize melanin in organelles known as premelanosomes or melanosomes. So the organelle in which they synthesize melanin is called premelanosome or melanosome. And when they are phagocytosed, it is called a melanophage or melanophore. So you have to differentiate between the terms melanosome, melanophage and melanophore. Melanosome or premelanosome is the organelle in which they synthesize melanin, and when this is phagocytosed, it is known as a melanophage or melanophore, right? Next cell is Merkel cell. Merkel cell is located in the deep layer of the epithelium or the basal layer. You can see the figure, right hand end. They harbor nerve endings. They are tactile perceptors, okay? And they are connected to the adjacent cells by desmosomal attachment. They have to transmit the touch sensation. Therefore, they have to have adjacent cellular attachment with the help of desmosomes, and definitely the nerve endings, everything is present in the connective tissue. So to have contact with the connective tissue, it should be located in the deep layers of the epithelium or deep layers of the stratum basale. So that is the location and function of Merkel cell. The third clear cell is Langerhans cells. Langerhans cells are also dendritic cells like the melanocyte. You can see the figure. They are located among the keratinocyte at all suprabasal levels. You can see melanocytes and you can see Merkel cell in the basal cell layer, but Langerhans cells are not found in basal cell layer. They are found in all the suprabasal cell layers, and they belong to the mononuclear phagocytic system or the reticuloendothelial system. These cells are modified monocytes. Very important. Langerhans cells are modified monocyte. We saw modified lysosome. What was that? Our keratinosome or Odland body was a modified lysosome. Langerhans cell is a modified monocyte. It is the antigen presenting cell for lymphocyte. And one more important question is, Langerhans cells possess a specific type of granule. It is known as G-specific granule or Birbeck granule, and they have marked ATPase activity. So that is the important thing about Langerhans cells. So three non-keratinocytes or clear cells are melanocyte, Merkel cells and Langerhans cells. Another question is about the metabolic pathways happening in these cells.
are a pentose pathway, or which is an alternate pathway of glycolysis, such as glucose 6-phosphatase enzyme, which is involved in the pentose pathway, will increase their activity towards the surface. So pentose pathway enzymes like glucose 6-phosphatase have an increased activity towards the surface. Why is this so? Because this pathway is involved in the production of RNA, and RNA is very important for synthesis of protein. Which protein in this case? Specifically keratin. So pentose pathway is important for RNA production, for production of protein. Therefore, where we see keratin maximum in the superficial layers. So pentose pathway enzymes like glucose 6-phosphatase are found maximum towards the surface layer. Whereas succinic dehydrogenase, nicotinamide adenine dinucleotide NAD, cytochrome oxidase and such mitochondrial enzymes, they are more active in the basal and the parabasal layers. Why is this so? These cells are involved in more mitotic activity. So they should have these mitochondrial enzymes in much more concentration. And one more thing is the glycogen concentration of the gingiva. Glycogen concentration of gingiva is inversely proportional to the degree of keratinization and degree of inflammation. So if the glycogen is more, it means that is good. There is inflammation is less and degree of keratinization is also less. Another repeatedly asked questions are about the keratins. There are different type of keratins. Which keratin is present in which part of the epithelium or what type of the epithelium is very important. Keratins K1, K2, K10, 11 and 12 or K10 through K12 is present in epidermal type differentiation. So it is common in orthokeratinized epithelium. I used to think it is K1, K2, K10 and K12, but it is K1, K2 and K10 through K12, which means K10, 11 and 12. Okay, please make a note of that. So K1 to 10 through 12 are found in epidermal type differentiation or orthokeratinized epithelium. K6 and 16 are found in highly proliferative epithelium. Okay, 6 and 16 in highly proliferative epithelium. K5 and K14 are stratification specific cytokeratins and K19 is found in parakeratinized areas. Okay, so 1, 2, 10, 11, 12 was found in orthokeratinized, 19 is found in parakeratinized, 6 and 16 highly proliferative, 5 and 14 stratification specific. These are about the keratins. Now about the non-keratin proteins. We have proteins other than keratin also. Mostly we have keratolinin and involucrin. What is the function of these proteins? They are precursors of a chemically resistant envelope below the cell membrane. Our cell will have a cell membrane and below the cell membrane there is a chemically resistant envelope. So this keratolinin and involucrin are the precursor proteins for this envelope. Clear? One more protein is filaggrin. Filaggrin is packed into the keratohyalin granules, which becomes the matrix of the corneocytes. So basically keratolinin and involucrin forms the envelope below the cell membrane. Keratolinin, okay, it lines the cell membrane. And filaggrin becomes the matrix of the corneocyte. Clear? That's all about outer epithelium. Coming to the cellular epithelium. Cellular epithelium is non-keratinized, meaning to say it does not have these 4 layers. It has a basal layer and a suprabasal layer, but it has the potential to keratinize if it is reflected and exposed towards the oral cavity. Cellular epithelium faces the tooth surface and it is not exposed to the oral cavity. Once we expose it to the oral cavity, it has the potential to keratinize. Now 2-3 important points about cellular epithelium it can be asked. Which are the major keratins found in cellular epithelium? They express majorly K4 and K13. This is known as esophageal type cytokeratin. Or esophageal type keratin means the internal esophagus type of organs are not keratinized. So esophageal type cytokeratins like 4 and 13 are found in cellular epithelium, but it also expresses K19. You should say it majorly contains K4 and K13. Second important point is it does not contain Merkel cells. Merkel cells were tactile perceptors. They were found in the deepermost layers of the stratum basale. It was present in outer oral epithelium. It is not present in the cellular epithelium. A third point is acid phosphatase staining is negative in cellular epithelium. Acid phosphatase staining will be negative. Clear? The third part of epithelium is junctional epithelium. Junctional epithelium is the junction between the gingiva and the tooth. There are many unique features to junctional epithelium. It is a 3 to 4 layer thick structure in our early life, but it increases to 10 to 20 layer thickness. Length of junctional epithelium is an important question. It ranges from 0.25 to 1.35 millimeters. Okay. Then I told you there are many unique features. We'll go through those features. It has lower glycolytic enzyme activity than the outer epithelium. Glycolysis and glycolytic enzyme activity is less in junctional epithelium. It lacks acid phosphatase activity. Just like acid phosphatase staining was negative in sulcular epithelium, acid phosphatase staining or acid phosphatase activity is negative in junctional epithelium also. They do not possess Langerhans cells. Sulcular epithelium was lacking Merkel cells. Junctional epithelium is lacking Langerhans cells. They do not have Odland bodies. Odland bodies or keratinosomes or membrane coating bodies or lamellate bodies is absent in junctional epithelium. Junctional epithelium is continually self-renewing structure with mitotic activity in all the cell layers. That is also very important. Usually the mitotic activity is restricted to the basal layer. Junctional epithelium exhibits mitotic activity in all the cell layers, and even though there is injury to the junctional epithelium or any insult to the junctional epithelium, it can self-renew. Okay. In sulcular epithelium, we saw it is a non-keratinized epithelium, so it is expressing esophageal type of cytokeratins like K4 and K13 and less of K19. But junctional epithelium, as I told you, it's a unique structure. It is showing all ulta characters. Even though it is non-keratinized, it is lacking K4 and K13 expression, and it expresses K19. And the basal lamina of junctional epithelium is also different. It is lacking type 4 collagen. We have learnt 4 on floor, right? So most of the basal laminas have collagen 4, but in junctional epithelium that is also lacking. By the way, what is the difference between basement membrane and basal lamina? We know basement membrane separates the epithelium from the connective tissue. Basement membrane is the name of the structure when we view it through a light microscope. Basal lamina is the same structure. Basal lamina is same as the basement membrane, but we call it lamina when we view it through a electron microscope. So it is a more detailed view. Another term is dentogingival unit. The junctional epithelium plus the connective tissue fiber is considered as a functional unit, and this is known as the dentogingival unit. By the way, the junctional epithelium plus the connective tissue fibers is known as, yes, it is known as the biologic width. Coming to, as we know, it is non-keratinized junctional epithelium, and it has 2 layers, basal layer and suprabasal layers. So the basal layer faces the connective tissue and the suprabasal layer is facing the tooth surface. So the junctional epithelium, suprabasal layer is facing the tooth surface. How is it attached to the tooth surface? It attaches to the afibrillar cementum present on the crown surface. So basically junctional epithelium is attaching to the cemental surface and not to the enamel surface, right? One more thing is junctional epithelium, as we said, it is a self-renewing structure. It is completely restored within about 5 days in primates. When there is some injury or some insult to the junctional epithelium, it can completely restore in 5 days. That's all about epithelium. Coming to the connective tissue of the gingiva. Connective tissue of gingiva is also known as lamina propria, and it has 2 layers, papillary layer and reticular layer. As we know, there are retapex or projection of the epithelium into the connective tissue, or these dips is known as retapex, and this finger-like projection, that area of the connective tissue is known as the papillary layer, and the basal portion is known as the reticular layer, right? There are 3 types of connective tissue fibers: collagen fibers, reticular fibers, and elastic fibers. Predominantly it will be collagen fibers, and the elastic fiber system is composed of oxytalin fibers, elastin fibers, and elastin fibers. These will be distributed among the collagen fibers. The collagen fibers of the gingival connective tissue is arranged in different bundles. Okay, so there are 5 principal fiber groups. First one is dentogingival, second one is alveologingival, third is dentoperiosteal, fourth is circular, and fifth is transeptal. First group is dentogingival. Just look at the term dentogingival, tooth to gingiva. So look at the figure also. It runs from the tooth cementum and it splays into the
gingival connective tissue. There are 3 subgroups of the dentogingival fibers, A, B and C. Look at the figure. The A subgroup, it will turn coronally and obliquely into the free gingival margin from tooth to the free gingiva. Subgroup B is going into the attached gingiva and the apical part of the free gingiva. And subgroup C, it turns apically from the cementum and sweeps down across the crust of the alveolar bone and into the attached gingiva. So this is dentogingival fibers from the tooth to the gingiva or tooth cementum to the gingiva. It provides gingival support and provides support for the junctional epithelium and interdental papilla. Next is dentoperiosteal. From the term we know dentoperiosteal means tooth to the periosteum. So tooth cementum near CEJ, it inserts into the crest of the alveolar process and lateral aspect of the cortical plate. And how did it become a gingival fiber? It passes through the gingiva. Okay. So dentoperiosteal, its function is to anchor the tooth to the bone and protection of the periodontal ligament. So that is the third group. After dentogingival and alveologingival, we finished dentoperiosteal now. Coming to circular group. Circular group is the smallest bundle group. It appears to be smaller in diameter than the other bundle groups. It is not running from any structure to any structure. It is just present inside the gingiva, inside the free marginal gingiva and the attached gingiva, and it encircles each tooth. Okay, so it do not have any attachment to any calcified structures. And what is the function of the circular group of fibers? It maintains the contour and position of the marginal gingiva. Marginal gingival position is maintained by the circular group of fibers. In figure, it is seen as small circular structures. Okay. Coming to transeptal group. About transeptal, an important point is it is best viewed in the mesiodistal plane. When it is cut in the mesiodistal plane, it is best viewed, but can also be viewed in the transverse section. Transeptal fibers run between cementum of 2 adjacent teeth. Runs from the cementum of one tooth to the cementum of the adjacent tooth, coronal to the alveolar crest. This is also not having any bony attachment. Since it is present coronal to the alveolar bone crest, it protects the interproximal bone and it supports the interdental gingiva and also maintains the relationship between 2 adjacent teeth. So these are the 5 principal fiber groups. In addition to the 5 principal fiber groups, we have some secondary fiber groups. Those are semicircular, transgingival, intergingival, interpapillary, intercircular and periosteogingival. We can see those fiber groups in the figure. Circular is a principal fiber, semicircular is a secondary fiber. Then we have transgingival fibers. Then we have 3 fibers starting with the term intergingival, interpapillary, intercircular, and finally we have periosteogingival. We learned about the features of the epithelium, we learned about the connective tissue. Coming to the macroscopic features or what we can see, okay, those features of gingiva. Color, first feature is color. Normal healthy gingiva appears coral pink or coral pink color with melanin pigmentation. What are the 3 major factors affecting the color of gingiva? This can be asked as like all except question. Factors affecting color of the gingiva are pigmentation. How much is the melanin pigmentation of that individual? Vascularity and keratinization. So pigmentation, vascularity and keratinization affects the color of gingiva. Second macroscopic feature is contour. The normal gingival contour is scalloped. It is scalloped with knife edge margins. But in case of inflammation, what happens? The scallop will be exaggerated and the margins, instead of being knife edged, it will become rounded. Right? After color and contour, we'll look about the size. Size of gingiva is the sum of cellular and intercellular elements and the vascular supply. Right? Whatever is present inside that structure, all these will contribute to the size of that structure. And size of the gingiva also depends upon some factors. There are 6 factors. The adjacent tooth, okay, it determines the size of the gingiva. The facial-lingual position of the tooth, okay, if it is lingually placed, then the size of the gingiva in the labial or the buccal portion will be more, it will be bulky. Mesiodistal position of the tooth also plays an important role. Then spacing between teeth, if it is present, again gingival size will be more. Carious lesions
if present, gingiva can grow into that space. Then proximal contact between two teeth. So these are the 6 factors which can affect the size of the gingiva. Coming to consistency. The consistency of normal gingiva is firm and resilient, tightly bound to the underlying bone. The factors determining the consistency of gingiva are 3. Collagenous nature of the lamina propria. The collagenous nature of the connective tissue determines the consistency. Then attachment of the gingiva to the underlying mucoperiosteum and the presence of the gingival fibers. These 3 factors determine the consistency. The firm and resilient consistency is the normal consistency of the gingiva. One more thing is, normal gingiva shows a feature known as stippling. What is stippling? Stippling refers to the orange peel appearance of the gingiva. It is very clear from the figure provided. Why is this happening? One of the hypotheses is there are alternating rounded protuberances and depressions on the gingival surface. When we draw the epithelium and the connective tissue, we know we draw retipegs, right? Alternating rounded protuberances. So one school of thought is that this rounded protuberances and depressions cause the stippling. And one more explanation is that the gingival fibers are firmly attached to the underlying periosteum. So because of this pull of the fibers, the stippling would have occurred is another school of thought. Anyway, the alternating rounded protuberances and depressions is the more accepted theory. Where is stippling found is an important question. Stippling is found in attached gingiva and mid-interdental papilla. It is easy to remember because the interdental papilla is actually a combination structure. Interdental papilla has part of free gingiva extending along its sides and part of attached gingiva dipping into its center. So attached gingiva and mid-interdental papilla, which is actually an extension of attached gingiva, shows stippling, whereas free gingiva never shows stippling. And this stippling will be lost in gingival infections. I am sure you are familiar with these microscopic features, color, contour, consistency and size, because we have been taking case histories, right? With that, we finished the microscopic and macroscopic features of gingiva. Coming to the periodontal ligament. So our chapter is gingiva and other tooth supporting structures. So we should cover periodontal ligament, cementum and alveolar bone. Don't bother, because only gingiva is this vast. Periodontal ligament, alveolar bone and cementum are relatively shorter topics. There are 6 synonyms for periodontal ligament. When you see any of these terms, you should identify it as periodontal ligament. Okay. So one is gomphosis, second term is desmodont, third one is pericementum because it is around the cementum, fourth one is dental periosteum, fifth one is periodontal membrane, and sixth one is alveolo-dental ligament. I don't expect you to learn all these 6 terms and reproduce. Just in case you see any of these terms, you should identify it as periodontal ligament. Now, principal fibers of the periodontal ligament. We had 5 principal fibers in gingiva. We have 6 principal fibers in periodontal ligament. And in gingiva, the fibers we were referring like running from here to here, dentogingival, alveolo-gingival, dentoperiosteal, transeptal, runs from cementum of one tooth to cementum of another tooth. Only circular one was like not running from anywhere to anywhere. That is how you should remember the gingival fibers. It runs from somewhere to somewhere. But the principal fibers of periodontal ligament you will easily get from this one diagram. Okay. The first one is alveolar crest. Consider a tooth root and an alveolar bone. The structure which connects the tooth and the bone is the periodontal ligament. So these fibers in the periodontal ligament from coronal portion to the apical portion are as follows. Alveolar crest fibers. It runs from the alveolar crest to the root cementum. It prevents the extrusion of the tooth and resists lateral movements. Second group is horizontal fibers. Look at the diagram. After the alveolar crest fibers, the next group of fibers are horizontal. Their direction is horizontal. This prevents lateral tooth movements. These fibers prevent the lateral tooth movements. Next group of fibers, as you can see, it runs obliquely in an opposite direction to that of the alveolar crest fibers. Alveolar crest fibers, from alveolar crest it was running coronally, whereas oblique fibers from the alveolar bone, it runs apically to insert into the root cementum. Okay. Maximum number of fibers are oblique fibers, and they resist the chewing forces or the masticatory forces. Next, the apical portion of the root is connected to the bone by apical fibers. This resists the forces of flexation and prevent the tooth tipping. Next is interradicular fibers. Consider a multi-rooted tooth. So, in between the two roots or in between the three roots of the tooth, these fibers are interradicular. And finally are transeptal fibers. Transeptal fibers are considered among the gingival fibers as well as the periodontal fibers. Transeptal fibers are the fibers without any osseous attachment. They run over the alveolar crest from cementum of one tooth to the cementum of the adjacent tooth. Clear? So 6 principal fibers are, just visualize this diagram and move from the coronal portion to the apical portion. You will get all the fibers: alveolar crest, horizontal, oblique, periapical, apical, interradicular, and finally are transeptal fibers, which are common to gingival and periodontal group.
Now, how the collagen is forming these collagen bundles? Okay, so collagen is a triple helical molecule. Collagen is a protein, so its basic unit is amino acid. The amino acid arrangement is glycine X Y, where there are 3 amino acid, so it is a triple helix actually, and 1/3 of the amino acid is always glycine. So the arrangement is glycine XY. And which amino acid is involved in cross-linking? It is glycine. Glycine is the predominant amino acid which is involved in cross-linking of collagen. We'll see the amino acids like glycine, proline, and lysine. They assemble. And they form a pro-collagen chain, or the amino acids combine to form a polypeptide chain. Then this pro-collagen molecule is formed by the triple helical conformation of 3 pro-collagen chains. We told already it's a triple helix. So the amino acids are arranged together to form a pro-collagen chain. 3 pro-collagen chains are arranged in a triple helix to form a pro-collagen molecule. The pro-collagen molecules will undergo some modification to form a tropocollagen molecule. Okay, so amino acid to polypeptide chain, 3 polypeptides chain form a triple helix and form a procollagen molecule. Procollagen molecule undergoes some modifications to form the tropocollagen molecule. Aggregation of the tropocollagen will form a collagen fibril. You can see in the figure it is numbered 6. Aggregation of the tropocollagen molecules form a collagen fibril with 64 nanometer periodicity. This is a repeatedly asked question. What is the periodicity for collagen fibril? It is 64 nanometers. You may know the value 64, but then they'll change the unit in the option. They'll ask a nanogram, picogram, all that. It is 64 nanometers, right? Now this collagen fibrils will aggregate to form a collagen fiber. So thus now we got a single collagen fiber, and fasciculi of all these fibers, or when these fibers are arranged in bundle, it is called a collagen bundle. Okay. Now there is a term called indifferent fiber plexus. What is it? It is a collagen molecule. It is a small collagen molecule which run in all direction to form a plexus, and it is termed indifferent fiber plexus. It is found in the periodontal ligament. One more thing about periodontal ligament, it do not contain mature elastin fibers. Other than collagen, we already said there are reticular fibers and elastic fiber system, and elastic fiber system has oxytalin, elastin, and elonin. Periodontal ligament do not contain the elastin, which is the mature form, but it has the immature forms oxytalin and elonin. Clear?
Now, other than collagen fibers, what do we have? We have cells. We have ground substance. The cell, predominant cell is fibroblast, definitely. And among the ground substance, we have to learn 3 terms: glycosaminoglycans, glycoproteins, and proteoglycans. Have you ever got confused with these terms? In simple terms, I'll explain. What is glycoprotein? What is proteoglycan? So, the ending part of the term is the basic molecule. A glycoprotein is a protein. Okay, it is modified by glycan or carbohydrate residues. So it is basically a protein with some amount of carbohydrate residue in it.
Whereas a proteoglycan is a heavily glycosylated molecule. It has large amount of carbohydrate with some amount of protein. Okay. Now what is glycosaminoglycan? Glycosaminoglycan is simply a polysaccharide. It has multiple disaccharide units in it. And we already said proteoglycans are heavily glycosylated structures. So proteoglycans usually contain a glycosaminoglycan residue in it. And the question which can be asked for you in entrances about the glycosaminoglycans in periodontal ligament, there are predominantly 5: chondroitin sulfate, dermatan sulfate, heparin sulfate, keratin sulfate, and one glycosaminoglycan which is not sulfated, that is hyaluronan. And one more important question is which glycosaminoglycan is absent in PDL? Keratin sulfate is absent in periodontal ligament. So this is about the ground substance. Now periodontal ligament contain one more structure known as the cementicle. This is also asked for exam. What is a cementicle? Cementicle is a calcified mass which is present in the periodontal ligament. They can be adherent to the root surface or they may be detached from the root surface. That's all about periodontal ligament. Now we have 2-3 slides on cementum and 2-3 slides on alveolar bone. Coming to cementum, Schroeder is the person who classified cementum to 5 major types. The types are acellular, afibrillar cementum, pretty clear from the term, no cells present, no fibers present. Acellular, extrinsic fiber cementum, no cells, extrinsic fibers are present. Cellular mixed stratified cementum, yes, cells are present, and intrinsic as well as extrinsic fibers are present. It is mixed. Cellular intrinsic fiber cementum, cells are present, intrinsic fibers are present, and finally we have intermediate cementum. Which type of cementum is present in which area and how thick it is? It is very important. It will be asked as MCQ. So, acellular afibrillar cementum covers the coronal cementum of humans. How come coronal cementum? Coronal portion should be having enamel, right? So we have learned 3 types of cemento-enamel junctions, CEJ. Among that, one was cementum overlapping enamel. You remember, right? So when cementum overlaps enamel, it is this cementum, acellular afibrillar cementum. So AAC or acellular afibrillar cementum covers the coronal portion, or it is the coronal cementum of humans, and it is very thin, 1 to 15 micrometers only is its thickness. Next one is acellular extrinsic fiber cementum. So just apical to this acellular afibrillar cementum, you can see acellular extrinsic fiber cementum. It covers the cervical third of the roots. So the cervical third means it is wider. It is 30 to 230 micrometers in thickness. It's a big range, 30 to 230. Third type is cellular mixed stratified cementum. You should come apically. A cellular extrinsic fiber cementum was in the cervical third, but cellular mixed stratified cementum is seen in the apical third of the root and in the furcation area of the multi-rooted teeth. Thickness is 100 to 1000 nanometer. Again, a very big range, but easy to remember, right? 100 to 1000 is its thickness. Then we have cellular intrinsic fiber cementum, or CIFC. It fills the resorption lacunae. So this is a repeat question. Cellular intrinsic fiber cementum is found in the resorption lacunae area. So you are clear about the 4 types of cementum. Now what is the 5th type, or intermediate cementum? Intermediate cementum is a zone near the cemento-dentinal junction. That is, in the root after cementum we have dentin inside, right? So in the cemento-dentinal junction we can see the intermediate cementum. It contains cellular remnants of the Hertwig's epithelial root sheath embedded in a calcified ground substance. So it is found near the cemento-dentinal junction, and it shows the characters of both cementum and dentin. That is why it is known as intermediate cementum. Next, a very important concept we should be clear with is difference between primary cementum and secondary cementum, or acellular cementum and cellular cementum. Primary cementum, from the name itself, it is the first formed cementum. So a tooth, the enamel organ will convert to enamel, and apical to this we have to have the cementum. So first formed cementum, when it forms, definitely where it will be forming the cervical third or cervical half of this tooth, and It is long before the tooth reaches the occlusal surface. How will the tooth reach the occlusal surface? The cementum just started forming. So it is formed before the tooth reaches the occlusal surface. And from the name it is clear there are no cells embedded in this cementum. It is acellular. And every time we have noticed whatever is formed first will be of more quality. So acellular primary cementum is the better quality cementum. It is more calcified. And Sharpie's fibers make up most of this structure. Most of this structure is made up of Sharpie's fibers, and there are some specialities of this Sharpie's fibers. They are inserted perpendicular to the tooth surface. Okay, so it is more strong. It can withstand more forces. We said already, better quality cementum it is. The size, number and distribution of these fibers increases with function. It can increase with function. It can adapt better. And it is completely calcified. These fibers are completely calcified. Coming to cellular cementum or secondary cementum, it is formed later, or it is formed after the acellular cementum. And the cellular cementum already formed the coronal portion or the cervical third of the tooth. So what is remaining? The apical third of the root is formed by this cellular or secondary cementum, and it is formed after the tooth reaches the occlusal surface. Okay. And cellular cementum definitely contains cells. What cells? Cementocytes. And it is a lesser quality cementum. It is less calcified. And the Sharpie's fibers in cellular cementum have a parallel arrangement, which means the functional adaptation is not that good. And while the Sharpie's fibers of acellular cementum was completely calcified, in secondary cementum it may be completely calcified or it can be partially calcified also. Clear? Coming to hypercementosis. Hypercementosis is a generalized thickening of the cementum. Hyper means excess. So, excessive production of cementum or a generalized thickening of the cementum with nodular enlargement of the apical third of the root. It can also appear in the form of spike-like structures. Okay, hypercementosis can also present as spike-like excrescences. So we have some diseases associated with cementum. Paget's disease, it shows hypercementosis. Again, acromegaly, arthritis, calcinosis, rheumatic fever and thyroid goiter are the systemic diseases presenting with hypercementosis. Paget's disease we are all familiar. The other systemic diseases showing hypercementosis we should be thorough with: acromegaly, arthritis, calcinosis, rheumatic fever and thyroid goiter. Since we can remember Paget's, the other disease names can be put into an acronym form: CART, calcinosis, acromegaly, arthritis, rheumatic fever and thyroid goiter. Now, periapical cemental dysplasia, condensing osteitis and focal periapical osteopetrosis. These are the diseases which may be differentiated from the hypercementosis. Why? Or how can we differentiate? Because these entities are located outside the shadow of the periodontal ligament. So how is the arrangement? Cementum, and outer to the cementum periodontal ligament, and outer to that we have the alveolar bone. So in hypercementosis it is just an excess of the cementum. So it is within the confines, it is in its position. So it is located inside the shadow of the periodontal ligament. But in case of periapical cemental dysplasia, condensing osteitis and focal periapical osteopetrosis, it is outside the shadow of the periodontal ligament and lamina dura, and that is how we differentiate these diseases from hypercementosis. Coming to alveolar bone, which is the last structure. Look at the figure. We have alveolar process and basal bone. Okay, alveolar bone has alveolar process and basal bone. What is alveolar process? Alveolar process is the portion which forms and support the tooth socket. So where the tooth root ends or where the tooth socket ends, alveolar process also ends, and below that we have the basal bone. Now we'll explain about the alveolar process. Alveolar process has an external plate of cortical bone. See the figure. There is a outer plate which is formed by Haversian bone and a compact bony lamellae. Then we have an inner socket wall. Inner socket wall means it is immediately near the tooth root, or it forms the socket wall. It is also a thin compact bone, and it is also known as alveolar bone proper or bundle bone. Why bundle bone? Because bundles of collagen fibers from the periodontal ligament is inserting into this portion or the alveolar bone proper. This structure, the alveolar bone proper or bundle bone, is known as lamina dura in the radiograph. Okay, so the bundle bone is lamina dura, and histologically it is known as the cribriform plate. Why cribriform plate? Because it has numerous openings for the neurovascular bundles linking periodontal ligament and the bone. We already said the external cortical plate and the inner socket wall both are compact bone. In between these two, we can see cancellous bone or trabecular bone or spongy bone. We can see that spaces, okay, the spaces which you draw in between the outer and the inner wall, this is cancellous bone. It is known as trabecular bone because of its trabecular arrangement. This is histological term. It is also known as spongy bone because of its consistency, soft or spongy consistency. It is an anatomical term. Okay. There are two types of trabecular arrangement, type 1 and type 2. Type 1 arrangement, the interdental and interradicular trabeculae are very regular and they show a horizontal ladder-like arrangement. So, the good quality arrangement is type 1 arrangement. Regular trabeculae which shows a horizontal ladder-like arrangement which is common in mandible. Type 2 is a irregularly or haphazardly arranged trabeculae. It is numerous and delicate. Okay, it is commonly found in maxilla. Now I'll clear a doubt which I always had. What is lamellar bone? A lamellar bone just means mature bone. It can be compact bone, it can be cancellous bone. A mature bone has lamellar arrangement and hence it is known as lamellar bone. Okay, see the figure, there are three types of lamellae: concentric lamellae, interstitial lamellae and circumferential lamellae. What is concentric lamellae? This make up the lamella of the osteon. Osteon is the basic unit of a bone, and because of the concentric arrangement it is called the concentric lamellae. Now what is interstitial lamellae? The adjacent concentric lamellae around the osteons, they have some spaces. So the lamellae which is interspersed between these concentric lamellae is called the interstitial lamellae. And what is circumferential lamellae? This entire structure or this entire border is enclosed by the circumferential lamellae. So I hope it is clear. Concentric lamellae, interstitial lamellae, in between those, and bordering this entire structure we have the circumferential lamellae. What are the cells found in alveolar bone? We have osteoclast, osteoblast, osteocytes and bone lining cells. This osteoblast, osteocyte and bone lining cell are the different stages of the same cell actually, right? Osteoclast, we all know it is a bone destroying cell. Osteoblast is a bone forming cell. Okay, when this osteoblast get trapped inside the bone which is formed, it is called a osteocyte. And an aged osteoblast, it will flatten and it covers the bone surface and forms a protective lining. This cell is known as a bone lining cell. Now an MCQ that can be asked is a feature of osteoclast. Osteoclast is a TRAP positive cell. What is TRAP? Tartrate resistant, vanadate sensitive, acid ATPase. So osteoclast is the TRAP positive cell among all these cells. And where is osteoclast found? It is found in the Hauschilt's lacunae. When we discussed about osteoblast and osteoclast, I would like to tell you one more thing. This rank-wrangle concept you would have heard. We'll just make a concept little clear and we'll wind up. Osteoclast is the cell which harbors a receptor known as rank. Okay, that is receptor activated nuclear factor kappa B. But for the osteoclast to bring out bone resorption, it needs the help of the osteoblast. How? The osteoblastic surface possesses the ligand RANKL. It is the ligand for the rank receptor. So, when the RANKL ligand present on the surface of the osteoblast attaches to the rank receptor on the surface of the osteoclast gets activated and it can carry out its bone resorption process. So where is rank present? Osteoclastic surface. Where is RANKL present? Osteoblastic surface. This rank-RANKL interaction and coupling brings about the bone resorption. I'll tell you one more thing. What is OPG or osteoprotegrin? it is a structure which is analogous to the rank L ligand. So as we said, whenever rank L attaches to the rank, bone resorption happens. OPG is analogous to rank L. So OPG attaches to rank and it will inhibit the activation of osteoclast and subsequently inhibit bone resorption. So OPG is protective against bone resorption and RANGL brings about bone resorption. So one more question which I have seen is what happens to bone when RANGL or OPG ratio increases or decreases. When RANGL OPG ratio increases, bone resorption increases. When RANGL OPG ratio decreases, it leads to bone deposition. Right? I hope you're clear with the presentation. Read this repeatedly, whichever is highlighted have been already asked, so concentrate on those. See the figures repeatedly. Okay, if you have any doubt, you can contact me. Thank you.